Great.
Yvette, it's such a pleasure to have you again. The first time that you came and you were discussing the Black women's study,
Mhm.
we were just astounded at what you had learned over that 25-year period.
Yeah.
And we asked you to come back, and
Mhm.
now you're here. So
I'm
we're
back.
pleased.
I'm
And
back.
the floor is yours.
Well, thank you. Thanks for inviting me back. Thanks for persisting and, keeping up with me because I always like forget. I get an email and then, we were just talking about people not responding and it's not that I'm ignoring. I just say I'm going to get to them and it gets buried. So I appreciate you making it to the top of my inbox and sticking with me and having this rescheduled, this part two. So it's great to know that the last time was recorded, and so people have seen that. So what I was just going to do is like a brief overview, and then just talk about a couple of the sub-studies that I've been involved in. I talked about a few last time, but some of the other conditions within Black women's health study that I study and what we found. So I'm going to share my screen and okay. And can everyone see that? See the screen?
Yes.
Okay,
Yes.
great. So yeah, so this is part two. And so I just again want to introduce my colleagues who work with me. And at the bottom are two students, both master's students who worked with me over the last year. And so I just wanted to give them a shout out as well. So again, just a quick overview, so I don't repeat too much from last year, but the main reason that the Black Women's Health Study was conceptualized and followed up for funding or taken to a grant proposal and submitted multiple times before it was funded was it was important to understand uh, the risk factors for uh, many conditions and cancer in particular in Black women. And we wanted to follow the methods that were being used to study large cohorts of white men and white women and felt that we could do the same thing, following them every 2 years by postal questionnaires. So those other cohorts of white men and white women were usually around health professionals. So there's the nurses' health study, the physician's health study, the health professionals' health study, the women's health study, all of those based at Harvard, but all dealing with nurses, physicians, optometrists, other healthcare professionals. Uh, for the Black Women's Health Study, we went to Essence magazine, which I like to describe this as the sort of virtual or portable beauty salon. Like we know every household has this, every church lobby has this, every beauty salon has Essence magazine. So the best way to get to where Black women are was through that sort of common feature. We also did invite um, members of the National Black Teachers Association, the National Black Nurses Association as well to join into the study. And in 1995, 59,000 women did indeed complete these postal questionnaires and joined. And so we've been following them every 2 years since. And then in this last period, we've now gone 3 years between follow-up cycles. Part of that is for costs. The NIH dollars don't go quite as far as they used to before, so we, have to spread out the intervals a little bit longer. But it also gives us an opportunity in those 3 year periods to do a little bit more deep dive work, and some of that is what I'll show today. So just a reminder, in 1995, when women enrolled, the median age was 38. I was shocked. I mean, it makes sense. We are now approaching our 30th anniversary, and now the median age of our participants is 68. So we've grown up together, if you will. Uh, about 80% of the women had education beyond high school, and we represented all regions of the United States. Again, we've mailed questionnaires every couple of years. We've asked basic health questions, lifestyle factors. We also ask questions around psychosocial stress like racism, trauma during early lifetime, and even more recently, stress. And we've also tried to assess chemical exposures. So I believe last time I talked about an analysis that we had done on chemical hair straighteners and risk of cancer. And, now the FDA is looking to ban certain substances from the chemical hair straighteners, in particular formaldehyde. But we've also, as participants have gotten older, looking at the memory and cognition and, of course, oral health. We've also assessed diet over these many years, not at every questionnaire cycle because the diet assessment is quite big, but every few years. We've collected biological samples from participants so that we can assess biomarkers and tumor characteristics and even genomics. And we've also linked data to Medicare as participants are getting older. Again, more women qualify for Medicare, so we're able to learn of health conditions through that. Also characterizing the neighborhood and what exposures they might be subject to in residential spaces, and certainly in follow-up for vital statistics. And of course, we try to stay in touch with our participants. We still publish a newsletter every 6 months. It's primarily online, so it's something that has changed over time. And of course, we maintain social media presence and have a participant advisory group that helps us in determining what questions to put on questionnaires. So, for data and findings, again, this is a list of the outcomes that we've studied to date. It's it's a bit extensive. The list of potential topics we could study, the things we've collected data on, is almost twice as big as this, but this is what we've been able to focus on. And so I will talk a little bit about oral health and also about sarcoidosis, a condition that I've been studying for pretty much the whole time that I've been part of this study. As I mentioned, we, with using blood and biological samples, we've been able to do genomic studies. So while we strongly believe that the environment is really the driver of many of the health outcomes that we have, how the environment interacts with our genes is also a driver of health conditions. So it is still important for us to explore the role of genes, but not the role of genes as the entire determinant of one's health. But certainly, again, it's what we consider a gene environment interaction. I thought I didn't put this slide out, but just a little bit of the racism questions that we had asked over time, assessing the day-to-day experiences and the lifetime experiences of racism and unfair treatment that women experienced were something that we looked at. So I just want to turn quickly to oral health. And so this was something that I was always very interested in. It always amazed me, and to this day, it still amazes me that when you look at the prominence of medicine over dentistry, medicine gets really all the love, gets all the resources, gets all the attention. Yet everything goes through our mouths, right, to the rest of our body. And that we treat oral health like it's a throwaway, like it's an addition, it's a privilege to have healthy teeth and gums, and that somehow that's not connected to health, but that's not at all what what we believe, and that's also not what the literature shows. The mouth is one of the most important organs in the body, and just tracking it from early childhood to old age, when children start to develop their teeth, um, sometimes people don't make light of it, don't worry about it, they're going to fall out, they're going to get teeth that grow back. But when teeth are lost too early, and that interval between the primary teeth and permanent teeth is long, a lot of sort of nutritional habits are influenced in that period of time. Speech is influenced because you actually need the teeth to help form words, and how your tongue, and palate interact with speech. So just kind of, making light of oral health early in life can have long-term consequences. When it gets to older age, the policy for Medicare for many years, and I think it's just changing, is they will remove your teeth, but they will not pay for dentures. So you have elders who might have no teeth. And we take that, again, it's kind of teeth are a throwaway, but that also affects not only their nutritional status and their speech, it affects their social ability and other things. And then when the gums are not healthy at all, we've seen connections with cardiovascular disease. We've seen connections with cancer. We've seen connections with other inflammatory disorders. So the teeth are very important. So I'm just looking at Zarina Costello's comment that part of the CSH curriculum is oral health. And yes, Dr. Donna Williams. Excellent. I mean, oral health has to be right there with physical health, and that that they're not treated on the same level, I think is a big mistake. So what did we do with oral health in this study? So we asked questions across the years. We put in our first set of questions in 2007, and we asked a very basic question. As an adult, how many teeth have you lost due to tooth decay or gum disease, right? We wanted to make a distinction between teeth being lost, perhaps due to an accident or something. And that was simply because with tooth decay and gum disease, that those are the conditions that have the greatest association with things like cardiovascular disease, with cancer and other chronic diseases. Then started to expand the question a little bit more. Overall, how would you rate the health of your teeth and gums? And in the past 4 years, so, since 2007, how many teeth have you lost? And then did a dentist ever tell you you had gum disease with bone loss? So that's like the other piece. When you have gum disease, it's not just that the teeth fall out, but the entire structure that hold teeth in place begins to erode. So, the jaw can start to change its shape. And again, that can lead to changes in nutrition, the comfort with eating food, the comfort with speaking, and other things. We ask how frequently people get dental cleaning, and then you can see how we've sort of repeated these questions over time. And we've, since 2015, asked the same battery of same general question: how would you rate the health of your teeth and gums? So in 2014, we did a validation study. We wanted to actually, ask women what they'd said about losing teeth, but we also wanted an opportunity to literally look in their mouths and to count the teeth that they had. How accurate was their self-report? So we did this study in Massachusetts. There were 700 participants in the Black Women's Health Study living in Massachusetts at the time. We mailed a 4-page questionnaire to them, asking many in-depth questions about oral health, and about 2/3 of them completed this question. And then out of those who completed the questionnaire, we invited them to come to Boston University School of Dental Medicine on the same campus where the Black Women's Health Study is located. We sit in the School of Medicine, and so the dental school is right next to us. And of this, 77 women agreed. And so when they came in, they got, they had a full dental exam that included counts of the teeth that they had, noting how many were decayed, missing, or filled, looking at their gums. So, pocket depth is kind of the distance between the tooth and how far down you can see onto like the root. And, attachment loss, were teeth loose at all. And we also took a sample for microbiome analysis. So we had a mouthwash sample in which they swished and spit so that we could look at kind of the pattern or abundance of certain bacteria. And we compensated women when they came, and we gave them parking vouchers and all. And I want to say one thing about how wonderful Black Women's Health Study participants are. I don't know how much snow New York got in the winter of 2015. Boston got like 140 inches over the winter. And it took until July 15th for our last snow pile to actually melt that year. So this was a dreadful year weather-wise. And of those 77 women who came, well, let me just say, 80 women agreed to come, 77 came. We only had 3 women who did not come in the middle of that type of weather. And they're coming to a dental school. Okay, so that's, pretty impressive on its own. So I'm forever grateful to the participants for that type of persistence. So, why did we want to do this? We wanted to be able to lay the groundwork for studying oral health in the Black Women's Health Study. So we could say to the NIH, we could say to reviewers of journal articles, what women have reported is actually pretty accurate. They're pretty clear on what's going on in their mouth, and they're pretty clear on and relaying that to us. So the data that we have is quite useful. So we did several studies, and I'm sorry, this little map is just kind of where our participants were sort of sprinkled around in the New England area at that time. And as I mentioned, we focused entirely on Massachusetts. But here's also a look at the questionnaire itself that we sent. So, again, asking how do you rate the health of your teeth and gums? Did you ever have been told you had periodontal disease? How often do you like brush and floss and all of these things? Have you had, replacements, dentures? Have you felt your dentures have not been fitting properly? So I know in dealing with my father, my late father, who had dentures, over time, his jaw shifted. He lost some weight, and the dentures didn't fit as well. And so he was much more uncomfortable using them. And with them not fitting properly and not being comfortable, he tended not to use them. And then when he didn't use them, he didn't want to go out. He didn't want to talk to people. The way he ate food, the food tasted different. So again, I saw the quality of life there within a family member. Looking at some of the other questions here in the middle around question 19, anxiety around going to the dentist. Yes, we all have anxiety. That's like probably the least fun exam ever. But there's, also, it can really, the anxiety can really keep people, one of the many things that can keep people away from a dentist. And then, thinking about, again, what happens to people as they have changes to their oral health, avoid eating certain foods, have pain, so again, decayed teeth, feeling depressed, having problems with your teeth and gums affecting your social activities, been worried about dental problems, not being able to function. And so we tried to get to all of these questions. So one of the first things we did, as I mentioned, we noted that what women were reporting was quite accurate. So we were able to validate this and rely on this. And then we also looked at some of the predictors of oral health. Having type 2 diabetes, being overweight or obese, smoking. These are all things that, have a negative impact on oral health and vice versa. We also looked at oral health in relation to pancreatic cancer risk, and we did find an association, confirming what other studies in white populations had been able to see. So I earlier showed you questions on the perceived racism. And we know that, in addition to dental anxiety, how you are treated when you come into the waiting room is also important. And if those experiences are not positive, they're very easy. They make the exam even worse, and they make it much more likely that people aren't going to go back. So we did actually see the women who had more frequent reports of experiences of racism had greater declines in how they rated the health of their teeth and gums. And at the bottom here, we looked at those experiences of racism were also linked to that issue of dental fear and anxiety. So it made, those experiences of racism made the already anxiety that many of us feel going to the dentist that much worse. Those women who had high dental fear and anxiety also had very high reports of experiences of racism. So, again, these social conditions can lead to unnecessary poor health through a number of ways, and through dental health is one way. So I just want to flip to sarcoidosis, and then afterwards I will answer any questions. I'm not sure how many people have ever heard of sarcoidosis. Has anyone on the call ever heard of this condition? Okay. So this is what we call one of the most common rare diseases ever, right? So it's a multi-system disease. It can affect really any organ of the body, but it tends to affect the lungs the most. It can range from an asymptomatic finding on an incidental chest X-ray to very progressive disease with fibrosis and need actually for, like organ failure or need for like organ transplant. Notable individuals who have suffered from sarcoidosis, the late comedian Bernie Mac died as a result of the lung fibrosis from sarcoidosis, and at the University of Chicago now has the Bernie Mac Center for Sarcoidosis Research that was set up by his family. The late Bill Russell, the NBA star, both he and his daughter suffered from sarcoidosis. And Tisha Campbell, who was on the show Martin, also is someone who has suffered from sarcoidosis. So again, it's it can be like from mild to, life-threatening, and, contributing to one's demise. Most patients can do well with no therapy. It might come on strong, but it could also go away. But then some percentage of it lingers and progresses. And the main treatment has been steroids, corticosteroids, which also have their own issues, because if they are maintained for long periods of time, it can lead to a lot of problems and uncontrolled weight gain, erosion of bone and cartilage and other things. So here, as I said, it can affect almost any organ. And what it is really like it is this response. The body's immune response system is responding to something. And so all of these cells kind of come together and form these what are called granulomas, right? Or almost like, tumors of these cells. And these cells can form in any organ when the condition occurs. Cardiac sarcoidosis is also another. The late Reggie White, the football player, played for the Green Bay Packers. He had a cardiac block, and upon autopsy, they found the granulomas. He had sarcoidosis. So, what causes this? Again, I talked before about, there can be some genetic predisposition, but there can also be environmental triggers. And really the two things together are what we believe leads to disease. So why am I interested in sarcoidosis? This was our baseline questionnaire in 1995. And you see, we've asked questions about, uh, diabetes, heart attack, cancer, things like that. And over 700 women wrote in sarcoidosis as an other condition. So we never even asked about it. It wasn't even part of the intended conditions to study. So we began to put it on subsequent questionnaires in every questionnaire since. And to date, we have almost 1,500 women who have reported sarcoidosis. About half of them, again, in 1995, so they already had the condition, and about an equal number have developed it over the last years of follow-up. So again, validating, we wrote to their physicians. We got their permission to write to their physicians to get information and details about their condition. We also asked the women themselves, can you complete this short questionnaire? When did you first, when you first diagnosed? What were your symptoms? Are you currently having problems? And importantly, do you have any family members who have been diagnosed? So again, almost 700 incident cases, new cases that have developed. We were able to confirm the diagnosis in 96% of the women. So again, very accurate in telling, reporting this condition. And so, it helped facilitated us being able to conduct other analyses. So one of the first was really this description in our study of this big cohort of Black women who had sarcoidosis. And overall, the prevalence or the number of women at any one period of time who had the condition in our cohort was about 2%. And we could see that the peak ages for being diagnosed or developing symptoms was, about 40 to 49. That was the peak time that most women reported that they were first diagnosed. We looked at clinical presentation and we compared it to the other previous study of sarcoidosis in Blacks and whites. So their study was about, the ACCESS study was over 700 people. Of the, 400 or so people who completed this supplemental questionnaire, we compared our data to theirs, and it is actually quite similar. So the ACCESS people had 95% have lung. It looks like 61% of ours have lung, but then if you look down below, the next one is intrathoracic lymph nodes. So that's still the nodes within the thorax that are closest to the lung, and it's usually a marker of lung condition. So if you add those two, we get 96%, they get 95%. So we're really right on target to what they're seeing in other groups. Skin is the next most common condition, and it's a condition called erythema nodosum, and it has like these particular nodules that can show up on the lower limbs, and then of course eye and other organs in the body. So what we also noted was in addition to sarcoidosis, 60% of women reported 3 or more other conditions, comorbid conditions. So they'd have sarcoidosis, but then they would also have asthma or type 2 diabetes or an autoimmune disease or hypertension. And so, there was really a heavy disease burden that these poor women had to endure. And when we looked at what their physicians were reporting in the medical record, they were also noting that, similar percentage, about 60% had at least one or more of these conditions. These were being noted in the medical record. I mentioned Bill Russell and his daughter. Familial sarcoidosis is something that happens. Other studies have shown, like 14% among any related family member, smaller percentages among first degree family members, so mother, father, sister, brother. And in African American families in particular, about 3 to 4% of siblings and about 7% of parents were noted to have had the condition. In relation to the person, I guess the patient themselves, they had either siblings or parents with the disease. In our study, 14% of first degree relatives. So this is higher than what was noted here. I mean, and there could be a little bias in our reporting, but 14% of our patients noted a first degree relative that had sarcoidosis, and then 28% noted that any relative, an aunt, uncle, first, second cousin, also had the condition. So we've looked, again, at many things. There had been some thoughts that women suffered from sarcoidosis more than men. And if that was truly a gender difference, it might indicate that hormones have a role. And so some medical case reports noted that, particularly around pregnancy, women with sarcoidosis, if they were to get pregnant, their sarcoidosis seemed to lessen, their symptoms lessen or even resolved, and then relapsed after they'd given birth. And then in some other countries, in Japan and Sweden in particular, it looked like there was a second peak in which older women were being diagnosed. So the thought was maybe that's around the time when menopause hits, so when there's a low estrogen state. So these are all hypotheses that were swirling out there. So we felt that we wanted to take a look at this in our population. And so looking at, age at which women start to menstruate and age at menopause, what we saw was older age of menopause actually had a lower risk. So we saw the absolute opposite from what the Japanese and Scandinavians saw. When we looked at pregnancy-related factors, older age at first birth and shorter intervals between birth also reduced the risk. Not a clear picture there, but we did not see anything when it came to oral contraceptive use or female hormone replacement therapy in older women who are menopausal. We didn't see any association there. We also looked at body mass index. So again, the hypothesis being that a high BMI was indeed like a state of low systemic inflammation. And where BMI is high, many of the immunosuppressive molecules in the body are lower, and they're more pro-inflammatory molecules. So that could cause immune systems to be a little bit more heightened. And that's perhaps why so many health conditions have been associated with higher body mass index. Also, there were, again, looking at other autoimmune conditions like lupus, and also in Denmark, again, in Scandinavia, they were seeing an association with sarcoidosis. So again, we wanted to look at this in our sample. And what we did see was, if you look on the left here first, having a higher body mass index at a younger age, so BMI at age 18, those women who had a higher BMI at that time, they had a higher risk, like a 40% higher risk of developing disease. When we looked at what their weight was when they began the study, okay, so many years later for some, again, higher body mass index also had a higher risk of developing sarcoidosis. And we looked at this not just in our study, but worked with our colleagues in the nurses' health study and asked them to look at this. And they found the same thing among white women, this increased risk according to body mass index. So there are a lot of questions around this. This is association does not mean causation. So we have lots of questions. Does body mass index influence the severity of the disease, for example, or how the disease presents? And there are other measures of adiposity or weight, like waist-hip ratio, waist circumference, and other things. We don't know if any of those measures are at all associated. We did find, my colleague Elizabeth Arkema in Sweden found a positive association in both men and women in Sweden with sarcoidosis. But a colleague here in the United States, looking at the Veterans Administration database of mostly men, did not find an association. So again, we don't quite know. Maybe this is where men and women diverge in the disease. We're not quite sure, but there's a lot of research that still needs to be done. But I'm very proud that within the Black Women's Health Study, we're really starting to lead this research going forward. So then just to wrap up, where are future directions, particularly with sarcoidosis? We are, have now updating some of the information of our participants, and the participant questionnaire is gotten bigger, right? So in addition to asking some of the questions that we did before about medications and symptoms at onset, we also want to know, as women are getting older, are they having greater burden of disease? Do they need assistive devices like canes and wheelchairs? Do they need supplemental oxygen? But also importantly, one thing that has not really been studied relating to sarcoidosis, in particular with Black women, is that how has it affected their financial situation? Have they become disabled? Has it greatly affected their finances or their employment status? Have they been able to work? Have they had to, go on disability? And we're also looking to see, is there any relation with other of these immunological diseases like Crohn's disease and ulcerative colitis, which are considered inflammatory bowel disease, arthritis, and other types of conditions. And then we're also looking at diet. Dietary patterns and vitamin D. So we have some preliminary data in which we've been able to look and see that women who had lower vitamin D levels had higher risk of developing sarcoidosis. So I'm just going to wrap up here for the whole study. Again, the Black Women's Health Study has been a very important study, certainly in my career, but I think that we have tried to really contribute to medical knowledge and to understanding risk factors that are much more unique to Black women, particularly when we look at things like the impact of racism and trauma and other things. Those are things that often get left outside of the exam room that people don't really consider, but and we feel that these are important. And also looking at diseases, rare diseases that tend to affect African Americans a bit more commonly, including sarcoidosis. So I thank you for your time, and I'm happy to answer any questions. So.
Wow, that was
Okay.
amazing. Thank
Yeah.
you.
Yeah,
Let
excellent.
me stop the recording. Hold on.
May I ask you a question while Lindy
Yes.
is